Hello, fellow classmates. Hello, Professor. My name is Alicia. This is for the course FMP 597. As you can see, I am at work. I do the night shift, so I am currently on my little bit of free time here. So for my soap note, I'm going to be presenting to you an asthma soap note. Patient initials AE, a 17-year-old male, a Latino male who has come to the clinic accompanied by his father for a sickness visit and appears to be in a distressing condition. He is composed, seems reliable, knowledgeable, and a good historian. The chief complaint, and I quote, "The reason why I have come to the clinic today is the breathing difficulties and wheezing I have been experiencing since yesterday morning." History of the present illness. A 17-year-old Latino male with new symptoms of the disease has reported to the clinic after an hour of difficulties in breathing and wheezing in the company of his father. He initially noticed the onset of the manifestations yesterday evening, shortly after his normal daily chores, with chest tightness and shortness of breath. During the episodes of difficulty breathing, he experienced discomfort like sharp stabbing pain, dizziness, and drowsiness. The patient also reports a mildly productive cough, usually occurring on exposure to a cold environment, that worsened hours after the initial symptoms. He was unable to sleep well due to breathing difficulties and could not lay in a supine position. The manifestations of the disease worsened through the afternoon and evening, and he initially thought to have a relationship with the hamburger he ate in the morning. He has been taking honey tea composed of a mixture of warm water and honey to manage the coughing, but the condition did not improve. The condition worsened after performing physical activities and was relieved after resting and avoidance of extreme physical activities. It is the first time the patient presents with such symptoms related to this condition in the clinic since his last visit 5 months ago. This patient past medical history, medication problem list. He is currently under hyperlipidemia treatment, diagnosed 4 months ago. He is now stable and following the treatment guidelines as directed by his healthcare provider. He has no other diagnosed medical condition apart from the condition present today. Any history of his surgeries and hospitalization history. He was performed an appendectomy and was hospitalized for 4 months 5 years ago. 4 months 5 years ago. Immunization, he is up to date with all his required immunization for a 17-year-old, receiving the tetanus booster vaccine 6 months ago, and he also received the second dose of the COVID-19 Pfizer 2 months ago, and his annual influenza vaccine, which he received today, or when I saw him in the clinic. And he's up to date currently. He has no known drug allergies or any food allergies. He is currently under simvastatin medication as directed by his healthcare provider, which he takes 20 milligrams PO in the evening. Family history: his parental grandmother was deceased at the age of 76. Due to asthma exacerbation and respiratory failure. His parental grandfather died at 75 due to pneumonia attack and also COVID-19 infection, apparently. Maternal grandfather was deceased from hypertension and obesity at the age of 80. And his maternal grandmother was deceased at 69 from a car accident, and she had a pre-existing hyperlipidemia. His father, who is alive, is currently managing his asthmatic condition, which was diagnosed 20 years ago. His mother, who is deceased after a long ailment from high blood pressure and type 2 diabetes. His sister, who is alive, is 25 years old, managing her overweight condition. And he also has a brother who's 20 years old, who is currently healthy without any diagnosed medical condition, who is currently also receiving an education abroad. Chemical history and alcohol. He does not consume alcohol or smoke tobacco. He denies consumption of any hard or illicit drugs. He denies exposure to toxic chemical in his neighborhood or his surroundings and in his household. His diet and exercise. He takes a diet rich in lean meats such as fish and incorporating a sufficient intake of whole grains, nuts, beans, vegetables, and fruits. With a limited intake of trans fats, saturated fats as directed by his family healthcare provider. He has been exercising for approximately a few hours a day to lower cholesterol levels after his school hours from guidelines given by this provider. He does not consume any caffeine. For safety wise, he wears a seatbelt while traveling and avoids engaging with peers involved in drug use. He adheres to the guidelines of protection against COVID-19 disease, wearing face mask and avoiding gatherings. There are smoke and carbon dioxide sensors in his homestead. He avoids prolonged exposure to the sunshine and uses sunscreen. He wears helmets and other safety parameters while exercising and maintains a high level of personal safety. He does not have an access to a gun. There's no possession of a gun in his home as well. He is active in his church activities, mainly participating in the community building activities and church competitions. There is no complaint regarding his social behavior, both in school, neighborhood, and in the community, and the majority perceives him as a role model. He admits currently exhaustion, general body weakness, dizziness, and drowsiness. He denies anorexia, sweats, chills, fever, or weight loss. All his objective or the subjective part of my soap is within normal limits. However, respiratory, he does admit breathing difficulties, wheezing, shortness of breath, discomfort, and some chest tightness. I do not hear any palpitations or murmurs, anything with any arrhythmia, cardiovascular wise. He does deny anxiety, depression, or suicidal ideations. Neurologically, he does admit to sleeping difficulties, of course, due to his breathing difficulty. Vital signs are as follows: temperature 98.5, respirations approximately 25 is what I counted, blood pressure 129/87, weight 112, oxygen saturation 96%, heart rate 93, his BMI is 18.6 kilograms, his height is 5'5", which makes him in the 13th percentile and at a healthy weight. The general survey of this patient: the patient is well nourished and groomed, neat, and dressed appropriately. He is responding to the interview accordingly, maintains eye contact, and interacting effectively. He is curious to get updated on his health condition and where he might be suffering from. Doing my general assessment on him. Everything seems to be within normal limits. However, the only concern was the respiratory section. I heard diffusely expiratory wheezing during forced expiration and diffusely decreased breath sounds bilaterally on auscultation. Cardiovascular wise, there was no murmuring, no galloping, no rubbing or palpitations. Capillary refills were less than 2 seconds. I heard S1, S2. Heart rate or heart rhythm seemed normal. Integumentary wise, no rashes, no jaundice, erythema, ecchymotic area. His skin was intact, dry, warm, and constituent with his ethnicity. Musculoskeletal wise, no edema. He had full range of motion in all his extremities. No pain or swelling in any of his muscles or joints. As I stated, the patient's very alert and oriented times 4. Normal mood and an affection was noted. Neurological wise, a little dizziness he complained of, fatigue, malaise, some drowsiness, of course, whereas he stated he wasn't getting much sleep. My primary diagnosis, I would find this as asthma. The diagnosis of this disease in this patient presenting with new disease symptoms is based on the family history of the illness, symptoms in the patient, and the physical examination findings. Since the onset of the manifestations, the patient complained of breathing difficulties, wheezing, chest tightness, and sleeping difficulties. The disease is confirmed for the diagnosis in this patient due to the symptoms, including coughing, wheezing, trouble sleeping, angina, and shortness of breath, which are observed in the patient. My differential diagnosis, of course, would have been COPD and bronchitis, where the reason why those were my differential diagnosis for COPD, which the disease is dependent on the manifestations of symptoms such as coughing, chest tightness, wheezing, and shortness of breath, which usually occur after physical activities. The disease is ruled out as the main diagnosis in this patient since it is manifested with swelling in the legs, feet, ankles, weight loss that the patient does not complain about. The physical examination does not reveal these additional manifestations. My third differential diagnosis would have been or is bronchitis. However, the diagnosis of this disease is based on the manifestations presented by the patient to confirm the diagnosis of this disease. The disease manifests discomfort in the chest, chills with fever, shortness of breath, fatigue, production of mucus, and coughing. The diagnosis of this disease is ruled out since the patient does not have chills, fever, or mucus production. Some diagnostic tests I would perform for an asthmatic patient: spirometry for estimation of the bronchial narrowing and check exhalation after deep breathing and breathing out. Peak flow for measurement of how hard the patient will breathe out to give indications of non-functioning lungs. Sputum eosinophils test to check the presence of white blood cells produced and the discharge produced during coughing. Imaging techniques using X-ray for identification of structural abnormalities that would result in aggravation of breathing problems. My plan for this patient of mine, the plan will aim to lower the exacerbations of the manifestations in the patient and prevent the emergence of complications using treatment, therapeutic, and non-therapeutic interventions. Pharmacological treatments, I would have prescribed inhaled corticosteroids such as Flexhaler, which is administered 360 mics through oral inhalation, BID, and the dose is increased until asthma stability is achieved. The side effects of these medications include sneezing, nosebleeds, stuffy nose, bad taste in the mouth, and voice changes. Combination inhalers such as budesonide, formoterol, which I would also prescribe, which will be administered at 80 over 4.5 micrograms BID oral inhalations. The benefit from the treatment begins 1 to 2 weeks post-treatment. The side effects of this medication include sinusitis, lower respiratory infections, thrush, pain, and irritation in the throat. Another quick relief using short-acting beta blockers that act immediately during asthmatic attacks, such as levobuterol administered as a nebulizer solution, 0.63 milligrams TID every 8 hours. The side effects of this drug are irregular heartbeats, constipation, leg cramps, pounding heartbeats, choking, and wheezing. Now, those are my non-pharmacological therapy. I would avoid asthma triggers by conditioning the air, maintaining optimal humidity, cleaning surfaces regularly, and covering the mouth and the nose when it is cold. Maintenance of a health weight by avoiding overweight, which would worsen the asthma conditions. Getting regular exercise to control symptoms emergence during the physical activities. Breathing exercises to aim the reduction of the intake of medications. Patient education on the importance of adhering to medication, understand the side effects of medication administration, follow-up periods after 2 weeks, and referral to a radiologist and an allergist. Thank you for listening, and that is my presentation on the Asthma SOAP note.